Good afternoon, everybody. My name is Mary Kate. I'm the nurse manager on 3 Cohen. Can everyone hear me well enough? I just want to make sure that okay. I'm here to talk about niche, which is a great program we started here at the hospital a couple of years ago. niche stands for Nurses Improving the Care of Health System Elders. niche is a program that is nurse-led. It's an international program that was started at NYU to improve the quality of care for adults 65 and older. niche facilities facilitates the integration of geriatric care model throughout the health system to provide our older adults with the specified care that they need. The mission of niche is to change the culture of care for older adults. The vision is that older adults receive age-friendly, geriatric-sensitive, exemplar nursing care. Our population is aging with higher life expectancies and complex medical care needs in addition to outpatient care needs. niche identifies the rapidly growing needs of older adults and helps develop a competency of health professionals to care for our geriatric patients. That's why there's so much purple in the presentation. It's only because and why you did start it. Maybe one day we can change the colors. So our challenge is that older adults are more likely to experience longer lengths of stay, higher rates of readmission, which is we count within 30 days, higher rates of functional decline, and higher rates of iatrogenic complications, i.e. hospital-acquired infections, falls, and so forth. Here at North Shore University Hospital, 46.3% of our patient population is over the age of 65. niche helps provide us the tools and resources to provide high quality care for our older adults throughout their hospitalization. I have this slide up here, which I was thankfully given by some of our quality data analysts to show our patient population in various areas. So our highlighted yellow units are, which I'll get to, is our niche pilot units, 3 Cohen, 3 Tower, 4 DSU, 5 Monty, and the surge areas as well. You can see that from 2022 to 2023, we did have even a significant increase just in our patient population over the age of 65. 3 Cohen up to 68%, 3 Tower, as we well know, is does have 33% this year. But even if you look at the other units who, and I'll get to the part of the niche program, 61%, 71%, 72%, again, 72%, 69%. Our population is aging and it is in all areas of our building. So we really need to pay attention to the sensitive care we provide these patients. Benefits of niche. As I mentioned before, the benefits of niche include decreased length of stay, decreased restraint use, decreased readmissions, falls, hopefully decreased rates of delirium, urinary incontinence, HAPIs, as well as decreased pain. Increasing mobility and function and improved staff job satisfaction are 2 other benefits of niche, which we get through our hard work. We want to increase safety and decrease iatrogenic complications for our elderly patients. niche also aligns with our magnet redesignation by adopting magnet philosophy, transformational leadership, structural empowerment, exemplar professional practice, and new knowledge, innovations, and improvement to reach empirical outcomes. So a little bit about aligning niche and magnet. Niche and magnet go hand in hand as they both strive for excellence in nursing to promote positive patient outcomes. Magnet recognition strengthens our niche program by adopting magnet philosophies, principles, and best practices. Niche and magnet are both recognized nationally as gold standards, and they're both on a journey to promoting, recognizing, and striving for nursing excellence and quality of care. Just like magnet affirms the culture of excellence and top quality nursing care, niche has geriatric care expectations and accountability that must be hardwired in our organizational structure and organizational culture with ownership and engagement by everyone. Both are system-wide and hospital-based nurse-led programs that are geared towards continuing to provide quality improvement in dual focus areas on patient and nursing care. So a little bit about our niche journey in the beginning up to now. We started our leadership education in August of 2021. We rolled out to our pilot units in 2022, including 4 DSU, 3 Cohen, 5 Monty, and the float pool. In 2023, we had a bunch of program development and expansion. We included 7 Tower and 7 Monty. I don't know why it's not on here. We presented at a national webinar on fall prevention, journey to the National Niche Conference. We had Antoinette and Leanne, who went to the Niche Conference, and they had great feedback from that, and partnerships with our health volunteers. Our plans for 2024 include expanding to all service lines, including 3 Tower, creating our steering committee with community partners, doing community outreach, and submitting our portfolio by the end of the year to reach exemplar status.
Okay.
We've also chosen from the beginning of our journey 2 quality focus goals for our niche program, which are falls and counties. So again, our pilot units were 4 DSU, 5 Monty, 3 Cone in the float pool. We want to increase safety and decrease iatrogenic complications for our elderly patients. And that begins with staff-wide education on the entire niche program. And again, our 2 measurable goals are falls and counties. So I updated for this year, as we do in our dashboards, to try to decrease falls and counties both by 5% in the end of 2024. This is going to mean increasing functionality and quality of life for our elderly patients, as well as decreasing their length of stay and improving cognitive function. This is just some of our team members and partners, not only nursing leadership and nursing staff, but all of our providers, case management, our PT and OT speech departments, pharmacy, safety and engineering, patient and family centered care, our volunteer program, and our community partners are all key in making sure that we're able to complete all of the great best practices for our older patients. Something I want to talk about is the acute care of the elderly model. We call this an ACE unit. As many of us are aware, we have a new ACE unit in the building, thanks to Deb and all of her hard work. And this is a unit really focused, hyper-focused, I'll say, on best practices for elder care. So the definition of an ACE unit model is an inpatient hospitalized unit specializing in the care of older adults that aims to promote healing, reduce anxiety from hospitalization. The goals are to address unique needs of patients 65 and older with an interdisciplinary team of highly trained doctors and staff members. Family involvement and patient participation is really key to improving each patient's functionality and independence so they can return home as soon as possible. Proven outcomes of ACE units include improved ADL function, decreased symptoms of depression, increased ability to walk, discharging to nursing homes, reduction in restraint use, reduction in days until discharge, and reduction of high-risk medications. Patients and family satisfaction, as well as physician satisfaction and nurse satisfaction, have been proven on many ACE units. A little overview of how the ACE unit works. They have a mission statement to have strong leadership committed to partnership with a geriatrician, our providers, our interprofessional team, the medical director on that unit, nurse manager, geriatric advanced practice nurses, geriatric pharmacists, social work and case management, as well as patient care associates, dietitians, and our therapists play a key role. Team IDRs using our SPICES tool, which I'll talk about in a little bit, is really important on any of our ACE units, any of our niche units that care for our older adults. A little summary of 3 Tower. Deb Recchia is our manager there. 3 nurses and 3 PCAs per shift on that unit for their patients. Partnership with Dr. Cast, Renata, and Dr. Chu, geriatric hospitalist. They have a 10-bedded unit. In addition to PICU, there is a day room there, which I have photos of. This inpatient hospital unit is specialized in the care of senior adults and aids to promote healing and reduce anxiety from their hospitalization. The same things I had mentioned before. This is also, as we know, helped to reduce our one-to-ones in the building a lot because the patients go there. They have a very calm environment. Deb has a day room for them. They have activities to do. We're able to decrease our one-to-ones, our restraints, and increase those patients' functionality and ambulation as well. Pictures of the activity room with Protect PHI. Debbie covered all their faces. But the room's really great. If you haven't been there already, please take a trip over and take a look at it. I'll talk about our geriatric resource nurses and geriatric PCAs. So on all of our niche units, we have our staff enrolled in the Niche Knowledge Center, which is a website. And to become a geriatric resource nurse or geriatric PCA, the staff have to complete a pathway of learning modules where they learn about the niche program and best practices. They do get CEUs for this, and nurses can use it towards certification. These are our 2 flyers, which I do have copies up front. For anyone on the niche units, in addition to anyone outside of the niche units who's interested, we can get them enrolled in the Niche Knowledge Center to complete the modules. Then they become a champion, so to speak, on their unit, either nurses or PCAs, to drive best practices for older adults. This is a little bit of what the dashboard looks like on the niche website. You can see there's catalogs, there's enrollments. Not only can the staff complete the required education modules for each role, but there are webinars on here, extra training, extra tools, which I'll talk about some of the tools they have later on. But there are amazing resources on here for continuing education. The fall webinar that we completed last fall is on here. The webinars stay up, so if you miss one that goes live, you can always log in and look at one later. Staff can complete CEUs on the Knowledge Center dashboard as well. Their geriatric resource nurse model. So these are our nurses that function as unit-based educators, advocates, role models, and champions of best practice for older adults. The GRN model promotes individual advancement in knowledge and skills, which can be recognized through our clinical ladder program. It is recommended that nurses use the SPICES acronym as a systemic method to identify problems with our patient, commonly in hospitalized adults, which I'll go over in a little bit. The GRNs gain enhanced skills in the care of older adults through education and training programs administered in the niche hospital by advanced practice geriatric nurse. The GRNs also play a key role in patient and family education. This is huge, as well as our transitions and care planning for discharge. Benefits of the GRN model include low physical strength utilization, and this is because our GRNs are on our units. So I'll talk about later, we have champion meetings. So we really use a champion model here at North Shore. So I like to say this a lot. Our GRNs are also our champions. Our GPCAs are our unit-based champions. So decreasing restraint use, decreasing length of stay, fewer problems with pain and incontinence, immobility, increasing the sensitivity in the needs for older adults, as well as improving their self-perception on the unit. They're a great resource. Increased collegiality between disciplines and enhancing clinical ladder as well. A little bit about the geriatric PCA. Similar to the GRN role, just as important, our PCAs are crucial to the care for our older adults. Many of them are our skin champions. Many of them are our mobility champions. You know, they are in their rooms. They are changing patients. They're the ones looking at Foley's. They're the ones ambulating them to the bathroom a lot. So I cannot stress enough how important our geriatric PCAs are as well. Any PCA that's interested in caring for older adults who are passionate about it and can work closely with the GRNs and our colleagues to promote best practices in caring for our elder patients. They also complete the core curriculum on the niche website, which consists of active learning modules aimed at developing the geriatric expertise of the PCAs. They also act as champions for their colleagues as well as patients and families for best practices on the unit. You know, they're the ones feeding our patients as well. They're at the bedside. They can, I'll tell PCAs all the time, you should also be, you guys educate the families on how to feed these patients, you know, how to move their Foley over if we have to ambulate them to the bathroom, but also get the Foley out. Our niche quality focus that I talked about before, and I don't have our Q1 fall data, but our falls and counties are our 2 quality indicators that we really look at with niche. So our goals are to decrease both by 5%, at least this year. Falls, we partner with PT and ambulation aides, getting patients out of bed early, focusing on their AMPAC scores on whether they need physical therapy or what assistive devices they should be using, toileting schedules. Our delirium screening and BCAM screening in our assessments is key so that we can use that. If our patients screen positive for delirium, we already know that they're a higher fall risk. So all bed alarms and chair alarms should be on. As far as counties, partnering with our providers to DC Foley's, trial voiding on day 2 or 3, huddling before we send cultures, and daily review of our county, our Foley's, which I know we're all county champions as well. So those are all things we're reviewing every day, as well as increasing the mentation of our older adults and focusing on environmental stimuli. So I have some of our pilot unit data on here from 2023 and 2024 year to date. Again, I didn't have the fall data from Q1, but we are, you know, striving, doing all of our best practices for fall prevention and county prevention. fall task force meetings. A lot of our GRNs and GPCAs should be attending both of those meetings. So our quality focuses are falls and counties. We should be seeing representation from our niche staff at both the fall prevention task force as well as county champion meetings. So some of our best practices in caring for older adults, which I'll dive deep into a few of them, focused IDRs with our niche team members, utilizing the spices tool, which I'll talk about, and our niche pocket cards, utilizing the hospitalized older adult CPG, which is something that isn't that widely used right now, but we'll get there. Utilizing our meds to beds program with Vivo Pharmacy, ensuring environmental safety, mobility support with PT, OT, speech, and safe patient handling, incorporating and documenting goals of care conversations. And then some of the ones on the bottom, which are hyper important for our patients and families in transitions, are our case managers and transitions of care, close family input, our liaisons, as well as our GRNs, whether liaisons on some other units are not geriatric resource nurses, but thorough discharge information and support for those patients is really important. Our providers and ACPs ensuring that all of our patients have the proper outpatient follow-up is really important as well. This is the spices tool I've talked about. This is a tool that we use during IDRs that really reviews 6 of the most important items for any of our patients over the age of 65. Nursing education is ongoing with this. The clinical practice tools, protocols that reflect the unique needs of the patient population are tailored to reflect the goals and the culture of the unit. So all 6 of these items, even if we weren't focusing on the tool itself prior to adopting the niche program, these are all really important things that we should be hitting on IDRs. But now that we have this tool, when we're in IDRs, I know on my unit and I know on all of our pilot units, we make sure we touch all 6 of these things. This program is geared towards if all 6 of these things are addressed and we're preventing or making them better, it should only decrease the patient's length of stay and increase their positive outcomes. So SPICES stands for sleep, problems with eating and feeding, incontinence, confusion, evidence of falls, which is also history of falls, as well as skin breakdown. So, those seem pretty simple when you look at them, but those are our key drivers here. So utilizing the SPICES tool when we're in rounds, we're talking about how is that patient's sleep pattern? Do they have difficult with sleep? Are they even sleeping? Do they have problems with eating and feeding? Do they have an appetite? What are their food preferences? Are they able to feed themselves or do they need assistance with feeding? Incontinence, observing their voiding and bowel patterns. Someone might be incontinent, of stool, but maybe they're not voiding. We have to be making sure we're monitoring their eyes and nose. We talk about CAUTIs, we talk about UTIs in our elderly patients. Are they voiding? And causes for incontinence. Not everybody is incontinent when they are at home, and they might be now that they're in the hospital, and that's a change that we have to evaluate. Confusion, establishing a baseline cognitive status. We get this all the time. Our patients come in, they have a history of dementia. So maybe they're alert and oriented times 2 to 3 at baseline, but they come in and they're ANO 0 and their family members telling us their altered mental status, they're so confused. And, some people are like, oh, well, they're confused at baseline, but there is a change. There can be a change from their baseline. So that's something we really should be listening to families and caregivers about and really taking note of. In addition to monitoring cognitive changes, we've all done iLearn and read in signs about our BCAM delirium screen, and that is really, really huge for our patients, especially if they do have a baseline of not being ANO4. That's going to tell us if they do have a change from whatever their baseline was. Evidence of falls, we want to ask about the history of falls for this patient. Not only have they fallen in the last 6 months, but how many falls have they had? Have they had any injuries? And evaluate for additional fall risk factors, medications, altered mental status. Do they have a Foley? What is around in their room, which I'll talk about environment later. And then skin breakdown, of course, our elderly patients, we're talking about skin breakdown, whether they have it and what their risk factors are. What's their Braden score? How much nutrition are they getting? Are they getting enough protein? Are we turning and positioning? So the SPICES tool is really comprehensive. I do have badge buddies up front if anyone wants to grab one with the SPICES tool on it, or I can send it out. But this is something that all of the staff on our niche units have as a badge buddy on them, hopefully. And I do have extras if anyone wants to take a look at those. But this is a really great tool that we use to make sure our IDRs are hyper-focused on all the really important factors for our older adults. This is a little slide about the hospitalized older adult CPG, which really should be used for most patients over the age of 65. It's in the plan of care flow sheet. You can add a parameter, hospitalized older adult, and it flows over some really great things into the A&I flow sheet. In addition to the plan of care, they're going to talk about education, about self-management and when to seek medical attention. But when it pulls over into our assessment flow sheets, it talks about environmental familiarity and consistency. Are the daily routines being followed? Are there familiar objects from home in the room? Are there personal clothing and items being utilized? It talks about rest and sleep enhancement. Are awakenings being minimized? Are we consistent with their schedule? Massage, and give them massages. And then sensory stimulation. Are there auditory simulations being minimized? Are we clustering care? Are we decreasing the lighting at nighttime and making it quiet so our patients can get the rest they need? So these are really awesome. We talk about skin injury risk prevention CPG, and we talk about fall risk or CPGs, but the hospitalized older adult CPG is really great. It brings over a lot of things that we're doing, but let's take credit and document that we're putting all these interventions in for our elder patients. Meds to beds is another best practice, which has grown definitely in 2024. And it is something that is really important to all of our niche units, in addition to any patient who, whether they're 65 or older, or whether they have other care needs, is a great thing. And we've gotten amazing feedback. So any patient who we want to do meds to beds for from Vivo Pharmacy, the scripts have to be sent directly to Vivo Pharmacy by the providers for bedside delivery before discharge. The scripts have to be in 2 hours prior to discharge so that Vivo has the time to bring them up. Providers should put a note in that script saying meds to beds. The patient will have a follow-up with Vivo 48 hours after discharge to review their meds and any concerns. We have had amazing feedback from this. It's a great program for older adults. We've had patients going, home, whether their family's here to pick them up or whether they're going home in an ambulance and their family's going to meet them at home, where, it is a big stress reliever for the family to know that the meds are physically with the patient. They don't have to worry about getting to a pharmacy before they close, or, making sure that they get delivered to the home the following day, because everything they need is going to arrive home with them. In addition to a lot of our liaisons, our GRNs, anyone who's doing discharges, being able to not only go over the discharge paperwork, but have the meds at the bedside to review. This is this medication, look at the label, this is what it's telling you. It can be very confusing and overwhelming, especially if one of our elder patients is being discharged home and their spouse is their caregiver and, they're also 80 years old. It's a great review. Environmental safety to support our older adults. So we have a lot of partnership with safe patient handling, with the safety and engineering departments for anything that we may need, but making sure we have clear hallways and reduce clutter. A communal dining room and activity area was great on ACE units, which now we do have on 3 Tower. Having the appropriate furniture. Do we have recliners? Do we have enough bedside tables for our patients? Color contrast for visually impaired, and warm colors to promote relaxation, which I think most of our units have. Signage in large font. Equipment, making sure we have adjustable beds, which we do, making sure we have bedside commodes, walkers, and alarm systems. We have our new Posey chair alarms that we have throughout the hospital now, our bed alarms, walkers, which we can order if anyone's missing any. I will give you the PeopleSoft number, but having enough walkers on the unit and having enough of the assistive equipment. I'll talk about our partnerships with safe patient handling and PT and OT, but making sure that we have all the equipment we need, which we can get, and it's here to ensure the safety of our older adults. Again, partnership with PT, OT, speech, all of our therapy departments. Early intervention and prevention is key to supporting our older adults. So our therapy and mobility teams play a key role in decreasing patients' length of stay, increasing their independence. Couple examples are We Mobilize program, getting people out of beds early and often, training on all of our niche units. Use of our ambulation aids, which I don't know if everyone knows about all the time, but if your patient can ambulate with one assist, PT will kill me, but call PT department. Sorry to get them on your ambulation aid list, because, I know it gets busy and sometimes our staff could use that support if a patient does qualify for the ambulation aid program, that they'll come and walk with them every day. Dysphagia screening and texture modification support that we have from the speech department when patients come in and maybe they're aspirating, maybe it's silent, maybe it's very audible, maybe we can tell. They partner very well with us on doing dysphagia screenings and speech and swallows, whether it's at bedside or patients having to go down for any testing. Caregiver and family participation is huge. Education, again, for our patients and their caregivers. Family members at the bedside should be being taught how to use the walkers, how to use a commode, what the best practices are to keep our patients safe. And again, getting patients out of bed safely. So I just had this on my unit. PT was with a patient and her daughter, and she was very insistent on her mother getting out of bed to walk. And PT said, you know, this is a max assist of 2 plus a Hoyer lift we had to use for your mom. It's not safe for one staff member to get her up. So really making sure that we educate our families and caregivers to explain why we do certain things, and so they don't think that we're either just leaving them there because we don't want to do anything. So really making sure we're explaining the processes and the safety modifications is big. Documenting goals of care conversations. So this is a really important thing that I know we do a lot on all of our niche units, but I was in our care model meeting recently too, and this is something that the ED providers have really been taking on and doing a lot with as well. Incorporating documentation of goals of care conversations can be done by the attending, the ACP, or the nurse. There is the opportunity for a nurse in her plan of care flow sheet to document a goals of care conversation with the family. That doesn't have to mean that the nurse pulled out a MOLS form and signed it, because that's obviously not a legal, legitimate MOLS form. But if you're admitting a patient, on the patient profile, it does ask about advanced directives. Do you have a healthcare proxy? And if a patient or their family member want to let you know that, oh, you know, my mom doesn't have one of those DNR forms, but we know that she doesn't want a feeding tube ever, and we'd love to talk to the doctor about that. That's something the nurse can put in their note. And at least we've documented, take credit for having that goals of care conversation, because that is something that really does get looked at when we talk about the care of patients who are 65 and older. I mentioned this before. Yeah, Jess. So sorry. A question we had in the room was, does that have question if it comes from someone who's their healthcare proxy or not? Is that what you're saying? Would it still be valid? So I think it depends on the patient. If the patient's alert and oriented ×4, right? If they're saying that this is my daughter, I don't have a healthcare proxy filled out, but I agree with her, and you know, I want her to make decisions for me. If the patient's not alert and oriented, then you know, gets a little bit more ethically gray there. But I think it's something that if they're expressing that, you can at least document this is being talked about. The providers will follow up so that we know that those conversations have started. But again, the nurses are not by any means filling out a MOLS form and signing it. That's not legal. Again, ED providers are documenting a lot of goals of care conversations. We saw a chart in our care model meeting about the rates that they've increased just since January of this year, and how it's a little difficult to do that in the ED. You know, people will look at you and think, I'm just here for like a broken finger, but it's the whole concept of just making that conversation, you know, more normal and having people comfortable with, you know, doesn't mean that something's happening right now, but what are your goals? Goals of care does not have to mean the patient requires end of life care at this time. And we should know the goals of care for any of our older adults. So if we are admitting someone over 65, you know, they might say, I don't have a healthcare proxy, I don't have a representative, but why? Let's encourage that. Let's tell them, you know, we would like to know what your goals would be and what you would want in the future. So this is another educational opportunity that a lot of our GRNs, our GPCAs, as well as anyone on the niche units has for our elder patients. So this is called a need to know flyer. It's another thing that we have on the niche website. That's a resource to our staff. I chose the pressure injury prevention one for today, just because HAPI wasn't a thing I was focusing too much on in the presentation. But these flyers come off the niche website. I know they're stamped with NYU. Somebody asked me in another meeting, can we erase that? But more to come. I don't know if we can, but this is a shared educational piece. So we're glad to take this on and use it. The flyers are all found on the Niche Knowledge Center. The flyers can be kept somewhere centralized in the nurses station, talked about in huddles and briefs at our monthly niche champion meetings. We have a different one that we focus on every month. Presenting the flyer to colleagues is a great way to get some clinical ladder points as well. And the flyers are easy to read and written in terms and patients that patients and families can understand. This is like the main part of this flyer. So somebody might not know what a pressure injury is. They might just call it a bed sore, but this explains what it is. It's localized damage to the skin and underlying soft tissue. It's going to explain what you and your family can do to prevent that. I have a couple other need to know flyers up here in the front if anyone wants to take a look, but there's ones on fall prevention, nutrition, maintaining physical function. How do I follow up with my providers as an outpatient after my hospital stay? How do I have, when should I seek medical attention? There's a plethora of need to know flyers, and they are really important, especially if we're having any of our liaisons or we have a discharge nurse on our unit. This is something that if we know somebody came in with a pressure injury or a UTI or a fall, grab the fall prevention one, go through it when we're doing their discharge. It's something that they can have at home. And like I said, super easy. Inspect your skin at the end of each day, clean your skin, dry and moisturize. These are things that the patients can understand, and they're written in these terms to be user friendly. So a couple things we have coming up. Niche at Skills Fair. I want to thank all of our educators and for helping us with this. Not only have all of our staff on all of our niche units gone through the baseline niche education that they get through their learning path, as well as iLearn modules that they were enrolled in. As of this year, we will start presenting niche at Skills Fair. So we're very honored and proud that the niche program will be part of Skills Fair. The RN education model that all the niche staff and GRNs have received will be summarized for almost all the RNs in the building. And this will be, I believe, a 45-minute session, unless I made that up. I think it's 30-minute session. Okay, that's fine. It's gonna, this will be a 30-minute session, but it's something that in addition to today, in addition to our monthly champion meetings, we can get the word out about niche. And maybe if someone's on a unit that isn't part of our pilot unit, or maybe they don't have that large of a geriatric population, that doesn't mean they can't still be a champion and best practice GRN. Very, very exciting. Big shout out to Leanne for helping us with this one. But we have made a cohort for gerontology certification for this year. So far, we've got I think we're over 20 names now for certification candidates. So if we all test and everyone passes, that would be really awesome, especially for our magnet journey. Plan to be testing between June and July. Everyone will be provided study guide material. If anyone who's not already on my list is interested, flyer is here. I can put it in the chat and you can scan the QR code. The exam cost will be reimbursed. Anyone who passes will receive the certification bonus at the end of the year. Open to all RNs who have not previously been in a cohort. So anyone who's done the med-surg cohort already won't qualify for the reimbursement, but nonetheless, enrollment is in iLearn under ANCC Success Pays, and you can reach out to myself or Leanne. All the information's on the flyer, so we're very excited about this. Thank you, Leanne. One of our other partners that's really important to us is the Help Volunteer Program. So Maureen Alderman from Patient Family Centered Care leads this program. Stands for Hospital Elder Life Program. It's a national volunteer program specifically working with geriatric patient population to help promote cognition and connection. So the Help Volunteers spend time with patients at the bedside, keep them cognitively engaged with conversations, learning about their interests, playing music, reading. They bring them games, magazines. These volunteers are great. They're always on my unit. I know that. Anyone who doesn't have the Help Volunteers coming around, please reach out I'll put Maureen's email. I can't believe I didn't put it on here. To myself or Maureen. The Help Volunteers are great. They spend a lot of time on my unit, so they really do great things with our elderly patients, and they'll even come by and see them. Yeah, I've had people come in when they're not actually working, volunteering on their own time. So a great program, and we get a lot of support from Maureen and her volunteers. A little bit about our niche champion and niche steering committee meetings. Our niche champion meetings are held monthly on Teams. The frontline staff, our GRNs and our GPCAs, as well as leadership and education, come together every month and talk about best practices, new initiatives. We do have guest speakers and of course, quality review. So we can look at our falls and counties each month and how we're trending. We have great participation in this meeting. It is a great place for us to funnel out information like any other of our champion meetings, our need to know flyer that we review every month, and any best practices. Recently, we talked about the hospitalized older adult CPG, so people can start utilizing that a little bit more. So like any of our champion model meetings, it's a great way to filter information down to all the staff on the units, whether they are actively a GRN or GPCA or not. So thank you everyone who participates in our monthly champion meetings. More to come. And this year we started our niche steering committee meetings, which will be quarterly. So we have community partners. I have a special thank you here to Ms. Carol Sendak, Ms. Nancy Kaplan, and Mr. Ralph Curcio. These are people or volunteers, community who have joined our steering committee meeting. And at our first meeting, they all had great ideas and great feedback for us as a facility. So I'm very excited looking forward to working with them in the future. Our interdisciplinary team for our steering committees, Dr. Kovassar, Kathy Green, Tom Lasala, and Chelsea Lettieri, Teresa Smith, Brian Russell, Sebastian Choi, and Doreen Cohen from all our different areas in the hospital have been key. Everyone joined our steering committee meeting and was really amazing in participation from the safety and engineering departments, volunteer offices, the providers, from the quality side and pharmacy. Everyone's really excited and really is engaged in providing support for our older adults. So that was really amazing. This meeting, we shared ideas, upcoming events and challenges, as well as changes, and we'll look at where we can make a positive impact in the future, hopefully with some community outreach as well. These are some flyers we had made for our steering committee where it says volunteers needed. That will be quarterly. And we have this little flyer for our niche designated units that we will post so that everyone knows when they walk on that they are on a niche unit. This is some information about the Alzheimer's Association. So I'll give a little shout out to Deb for this information, but she did have a meeting with them this year about the Long Island, the local chapter of the Alzheimer's Association, and gave us a lot of resources, which we're going to start implementing in the future, including an Alzheimer's rapid patient and family referral form. So if we have a patient or family who's really struggling with their patient, with their family member or loved one, or maybe they're the caregiver who has dementia, it doesn't have to be Alzheimer's dementia, any form of dementia, and they're struggling with caring for that patient or support, they can fill out this rapid referral form and call the local chapter, and they'll send somebody out and give them a lot of resources. So this is a really great tool and a great partnership that we're hoping to grow in the future. Hopefully planning to get involved with one of our local 2024 Alzheimer's Walk to End Alzheimer's Association walks this year. There's one, Fire Island might be hard, but North Babylon, and there is one in Nassau County. I think it goes out of Uniondale, but more information to come on that. So we're excited about this partnership as well. Our fall prevention webinar, which I spoke about before, we did back in September of 2023. Our leadership team presented a 60-minute national webinar. This was live streaming. Thanks to Antoinette, even she's part of our core team then, as well as Julia, who couldn't make it today. But the three of us presented a webinar on our best practices here at North Shore University Hospital. So we reviewed all of our best practices in fall prevention. We're able to share our innovation with the other niche teams across the country. People logged on from Illinois, Tennessee, from hospitals in those locations. And we really received amazing feedback from other facilities about our programs and initiatives, the use of AMPAC and IDRs, our chair alarms, our mobility team, the We Mobilize program. We had people calling us and emailing us like, oh my God, how do we get those chair alarms? Or we can't believe you guys do this. And, you know, it was really amazing to get all that feedback. So that was an exciting thing that we did this past fall that we will definitely have in our portfolio submission coming up this September. So some of our niche goals to reach exemplar status, which is the highest level of status we can reach for our niche designation. We plan to submit our portfolio in September. And some of our goals for this year to reach that, we're expanding our steering committee, which we've completed, participating and running a webinar, which we did complete, publishing a manuscript of our niche successes, which we're working on, adding niche education and geriatric competency to our skills fair. So that's something we've accomplished already. Increasing the number of nurses complete and PCAs completing their pathway, which we have completed already. In the orange is what we're working on, increasing the number of geriatric certifications. So hopefully that number will skyrocket by the end of the summer. Utilizing proper CPGs, which using this hospitalized older adult CPG I've mentioned is really important in capturing the care we're providing for older adults. And continuing to monitor our quality outcomes, reducing falls and CAUTIs. So hopefully we'll be able to make all those orange ones green by September to be able to submit our portfolio. And expansion into other areas, cardiology, ED, and looking at other facilities. We have found more hospitals in our health system than we even realized that have niche programs. So I'll be reaching out to hopefully the leaders of those programs so that we can coordinate and see if there's something we can do on maybe a system level to bring awareness. Couple thank yous. I want to thank Elena for her guidance on our niche journey and providing her expertise. Thanks, Elena. She's been key in helping us run. Leanne, thank you for your partnership with all of our education needs. Antoinette, even though you've transitioned to oncology, but really for getting our niche program journey started. Special shout outs to Julia and Rena from 5 Monty for their dedication. Ruby, Jenny, and Debbie as well for all their partnership and willingness to expand and continue the enrollment in our program.